I'm an emergency surgeon at Riverside General Hospital in Burlington, Vermont, or at least I was, until I submitted my resignation 8 months ago. You can call me Dr. Elena Vasquez if you want. During my 16 years in the trauma bay, I've seen everything you can imagine in emergency medicine: industrial accidents, motor vehicle collisions, cardiac emergencies, drug overdoses, and every kind of medical crisis that can bring someone to the edge of death. But what I'm about to tell you about is the one case that made me question everything I thought I knew about life, death, and the very fabric of reality itself, and ultimately led me to abandon emergency medicine entirely. The patient's name was Isabella Hartwell, and according to every medical record, legal document, and witness testimony, she died on my operating table on November 8, 2020. I pronounced her dead myself. I watched her body being wheeled to the morgue. I attended her memorial service. Yet on March 15, 2024, she walked through the doors of my emergency department, alive, breathing, and asking for help with what appeared to be a minor ankle injury. This is the story of how one impossible case shattered my understanding of medicine, reality, and what it truly means to be alive. Riverside General Hospital sits on the banks of Lake Champlain in Burlington, Vermont, serving as the primary Level 1 trauma center for northern Vermont and parts of New Hampshire. Despite Burlington's relatively small size, our emergency department handles over 85,000 cases annually, ranging from routine medical issues to complex trauma cases that require the most advanced emergency interventions available. The geography of northern Vermont presents unique challenges for emergency medicine. We serve rural mountain communities, busy interstate highways, numerous ski resorts, and industrial areas around Lake Champlain. During winter months, we see everything from skiing accidents and hypothermia cases to ice-related vehicle crashes. In summer, we handle boating accidents, hiking injuries, and construction site emergencies. As the head of emergency surgery at Riverside General, I worked closely with trauma teams, flight medics, and specialized units throughout the region. My typical shift involved managing multiple emergency surgeries simultaneously, consulting on complex cases, and making split-second decisions that could mean the difference between life and death for our patients. I had always prided myself on maintaining clinical objectivity and emotional control, even in the most challenging situations. Emergency medicine requires a certain psychological detachment. You learn to compartmentalize tragedy, focus on medical protocols, and accept that despite your best efforts, you cannot save everyone. Death becomes a clinical reality rather than an emotional devastation, because if you let every loss affect you personally, you wouldn't be able to function in the trauma bay. This clinical detachment served me well throughout my career. I could perform complex surgeries under extreme pressure, deliver devastating news to families with compassionate professionalism, and move seamlessly from one emergency to the next, without carrying emotional baggage from previous cases. I thought this mental discipline made me a better surgeon and a more effective emergency physician. I had no idea how thoroughly this worldview would be challenged by Isabella Hartwell's case. Isabella Hartwell was a 28-year-old environmental engineer who worked for Green Mountain Solutions, a renewable energy consulting firm based in Burlington. She lived in a renovated farmhouse about 15 miles outside the city with her partner Sophie Chen and their 2 rescue dogs. According to the information we gathered during her treatment, Isabella was an avid rock climber, kayaker, and environmental activist who spent most of her free time exploring Vermont's mountains and waterways. Isabella had been a patient at Riverside General twice before the incident that would change everything. In 2018, she had been treated in our emergency department for a dislocated shoulder sustained during a rock climbing accident at Smuggler's Notch. The injury was straightforward, an anterior shoulder dislocation that we reduced successfully with conscious sedation. She was discharged the same day with a sling and follow-up instructions. Her second visit occurred in early 2020, when she came to our emergency department with symptoms of what turned out to be a severe kidney stone. She spent several hours in our observation unit, receiving pain management and IV fluids before passing the stone naturally. Both of these previous encounters were routine, unremarkable cases that demonstrated Isabella to be a healthy, active young woman with no significant medical history or risk factors. When Isabella's name appeared on our trauma board on November 8, 2020, I recognized it from these previous encounters. In emergency medicine, you develop a mental catalog of repeat patients, some who return frequently with chronic conditions, others who seem accident-prone, and a few who stick in your memory for various reasons. Isabella fell into this last category because she had impressed our staff with her stoicism during both previous visits and her genuine gratitude for our care. What made Isabella's case even more tragic was the context of her life at the time of the accident. Sophie later told us that Isabella had recently been promoted to senior environmental engineer at her firm and was leading a major project to install solar panel systems throughout rural Vermont. They had been planning to get married the following spring and had just purchased the farmhouse where they lived together. Isabella was exactly the kind of young person who seemed to have everything ahead of her: successful career, loving relationship, active lifestyle, and a sense of purpose in her environmental work. November 8, 2020, started as a typical Sunday evening shift at Riverside General. Vermont had just experienced its first significant snowfall of the season, and our emergency department was busier than usual with weather-related accidents. Fender benders from drivers not yet adjusted to winter conditions, slip and fall injuries from icy sidewalks, then a few cases of carbon monoxide poisoning from people improperly using heating equipment. At approximately 7:23 p.m., our trauma team received an emergency call that would prove to be unlike anything I had encountered in my career. The initial report from emergency dispatch was confusing and alarming. A single vehicle accident on Route 108 near Stowe had resulted in what appeared to be a catastrophic rollover crash, but the details were unclear because the first responders were having difficulty accessing the scene. Route 108 through Smuggler's Notch is one of the most dangerous roads in Vermont, particularly during winter months. The narrow, winding mountain road features steep drops, sharp curves, and limited visibility. During heavy snow or ice conditions, the road becomes treacherous even for experienced Vermont drivers. The stretch where Isabella's accident occurred was particularly hazardous, a series of hairpin turns with a 200-foot drop into a rocky ravine on one side. The initial emergency call came from another driver who had witnessed Isabella's vehicle, a 2017 Subaru Outback, lose control on black ice while navigating one of the steepest curves. According to the witness, Isabella's car had spun completely around twice before crashing through the guardrail and rolling end over end down the rocky slope into the ravine below. What made the accident particularly devastating was the sequence of impacts. The Subaru had first struck several large boulders during its tumble down the slope, causing the roof to collapse and the frame to buckle. It then rolled at least 4 more times before coming to rest upside down against a cluster of pine trees, approximately 180 feet below the roadway. The volunteer fire department from Stowe arrived at the scene first, but they quickly realized they needed specialized equipment to reach Isabella's vehicle. The rocky terrain, steep slope, and unstable position of the overturned car made a standard rescue operation impossible. They called for technical rescue teams from Burlington and Montpelier, along with a helicopter from Dartmouth-Hitchcock Medical Center in case a flight evacuation became necessary. It took rescue teams nearly 45 minutes to reach Isabella's vehicle, and another 30 minutes to extract her from the wreckage. The Subaru's frame had been so severely compromised that rescue workers had to use hydraulic cutting tools to access the passenger compartment. When they finally reached Isabella, she was unconscious, trapped upside down in her seatbelt, and showing signs of severe trauma. The technical rescue team leader, Captain James Morrison, later described Isabella's condition at the scene as the worst survivable injuries he had encountered in 20 years of emergency response. She had obvious head trauma, suspected spinal injuries, and what appeared to be massive internal bleeding. Most concerning was the fact that she had been trapped upside down for over an hour, which can cause fatal complications even without other injuries. Due to the challenging terrain and Isabella's critical condition, the decision was made to transport her by helicopter directly to Riverside General, rather than attempting to carry her back up the ravine to a waiting ambulance. The flight medic team from Dartmouth-Hitchcock worked frantically to stabilize her during the extraction and transport process. Isabella's vital signs during transport were deeply concerning. Her blood pressure was critically low, indicating severe internal bleeding. Her heart rate was irregular, and often too fast or too slow. Most alarming, her Glasgow Coma Scale score, a measure of consciousness and neurological function, was only 3 out of 15, indicating deep unconsciousness and likely significant brain injury. The flight medic Sarah Rodriguez performed advanced life support procedures during the 12-minute helicopter flight to our trauma center. She established IV access, administered blood pressure support medications, and provided assisted ventilation because Isabella's breathing was inadequate. Radio reports to our trauma team indicated that Isabella had likely suffered what we call polytrauma, multiple life-threatening injuries affecting different body systems simultaneously. When I received the incoming trauma alert, the information was sobering. 28-year-old female, high-speed rollover crash with prolonged entrapment, suspected traumatic brain injury, probable internal bleeding, possible spinal cord injury, and unstable vital signs. The estimated time of arrival was 8:47 p.m., giving our trauma team about 15 minutes to prepare for what would clearly be one of the most complex emergency cases we had handled that year. Our trauma bay mobilization included myself as the lead surgeon, Dr. Marcus Thompson as the emergency medicine attending, Dr. Jennifer Walsh as our neurosurgery consultant, 2 trauma nurses, a respiratory therapist, and representatives from radiology and laboratory services. We also placed our blood bank on alert for potential massive transfusion protocol, given the likelihood of severe bleeding. The helicopter landed at our trauma center at 8:44 p.m., 3 minutes ahead of schedule. As the flight crew wheeled Isabella through our emergency department doors, I could immediately see that her injuries were among the most severe I had encountered in my career. Isabella was unconscious and unresponsive to verbal or physical stimuli. She had obvious facial trauma with significant swelling and what appeared to be skull fractures. Her left arm was clearly broken, with visible deformity suggesting multiple fractures. Most concerning was her breathing pattern, which was irregular and shallow, indicating possible brainstem injury or spinal cord damage. Our initial trauma assessment, which we called a primary survey, revealed multiple life-threatening injuries that required immediate intervention. Isabella's airway was compromised by facial swelling and possible cervical spine injury, so we immediately performed endotracheal intubation to secure her breathing. Her blood pressure remained critically low despite IV fluid resuscitation, strongly suggesting internal bleeding that would require emergency surgery. The secondary survey revealed the full extent of Isabella's injuries. She had suffered a severe traumatic brain injury with evidence of increased intracranial pressure. Her left arm had multiple fractures, including what appeared to be a compound fracture of her humerus. Most critically, her abdomen was distended and tender, indicating significant internal bleeding, likely from liver or spleen lacerations, caused by the multiple impacts during her vehicle's tumble down the ravine. Our CT scan results confirmed our worst fears. Isabella had multiple skull fractures with brain swelling and bleeding. Her cervical spine showed fractures at 2 levels that had damaged her spinal cord, most immediately life-threatening. She had massive internal bleeding from lacerations to her liver, spleen, and several major blood vessels in her abdomen. Dr. Thompson and I consulted quickly, and determined that Isabella needed immediate emergency surgery to control the internal bleeding. Her brain injuries were severe, but she would not survive long enough for neurosurgical intervention unless we could first stabilize her cardiovascular system and stop the hemorrhaging in her abdomen. At 9:31 p.m., approximately 90 minutes after Isabella's accident, we rushed her into our main operating theater for what would become the most complex and ultimately tragic surgery of my career. Our surgical team included myself as the lead trauma surgeon, Dr. Thompson assisting, an anesthesiologist, 2 scrub nurses, and a perfusionist standing by in case we needed to place Isabella on emergency cardiac bypass. The surgery began with an exploratory laparotomy, opening Isabella's abdomen to identify and control the sources of bleeding. What we found exceeded even our worst expectations based on the CT scan results. Isabella had massive lacerations to her liver, a completely ruptured spleen, and tears in several major blood vessels that supply the intestines and kidneys. The liver laceration was particularly devastating, is a grade V injury that had essentially split the organ into multiple pieces. Under normal circumstances, this type of injury is usually fatal unless the patient receives immediate surgical intervention and massive blood transfusion. The ruptured spleen had been bleeding freely into Isabella's abdomen for over 2 hours, contributing to her critically low blood pressure and shock. We immediately began our massive transfusion protocol, giving Isabella units of packed red blood cells, fresh frozen plasma, and platelets in an attempt to replace her blood loss and restore her clotting ability. During the first hour of surgery, Isabella received the equivalent of nearly twice her total blood volume in transfused blood products. The technical aspects of the surgery were extraordinarily challenging. We had to remove Isabella's completely destroyed spleen, repair multiple liver lacerations using advanced surgical techniques, and reconstruct several damaged blood vessels. Each repair required meticulous attention to detail while working against the clock, because Isabella's condition continued to deteriorate despite our interventions. About 3 hours into the surgery, we encountered a complication that would prove insurmountable. Despite our successful repair of the major bleeding sources, Isabella's blood pressure continued to drop, and her heart rhythm became increasingly irregular. The anesthesiologist reported that her blood chemistry was becoming more abnormal, with dangerous levels of acid buildup and electrolyte imbalances that suggested her organs were beginning to fail. Dr. Walsh, our neurosurgery consultant, had been monitoring Isabella's brain pressure throughout the surgery. At the 4-hour mark, she reported that the pressure inside Isabella's skull had risen to levels that were incompatible with survival. The brain swelling from her head injuries, combined with the physiological stress of massive blood loss and prolonged surgery, had created a situation where her brain was essentially being crushed inside her skull. As we entered the 5th hour of surgery, Isabella's condition became increasingly unstable despite our team's exhaustive efforts. Her heart rhythm had deteriorated into what we call agonal rhythm, an irregular, ineffective pattern that indicated her heart muscle was dying from lack of oxygen and the effects of massive trauma. The anesthesiologist, Dr. Patricia Kim, reported that Isabella was requiring maximum doses of multiple medications to maintain even minimal blood pressure. Her kidney function had essentially stopped, indicating organ failure. Most critically, her brain activity monitors showed patterns consistent with severe, irreversible brain injury. At 2:18 a.m. on November 9, 2020, Isabella's heart stopped beating effectively. We immediately began cardiopulmonary resuscitation, administered emergency cardiac medications, and attempted electrical cardioversion to restore a normal heart rhythm. For 47 minutes, our team performed continuous CPR, trying every available technique to restore Isabella's circulation. During those 47 minutes, we cycled through our entire emergency cardiac protocol, We administered epinephrine, atropine, and amiodarone. We performed chest compressions continuously, with team members rotating every 2 minutes to maintain effectiveness. We checked and rechecked her heart rhythm, looking for any sign that our interventions were working, but Isabella's injuries were simply too severe for human medicine to overcome. The combination of massive blood loss, severe brain injury, spinal cord damage, and multiple organ failure had created a cascade of physiological collapse that no amount of medical intervention could reverse. At 3:05 a.m. on November 9th, 2020, after nearly 6 hours of surgery and 47 minutes of resuscitation efforts, I made the decision to cease our life-saving efforts. Isabella Hartwell was pronounced dead at 3:05 a.m., with the cause of death documented as multiple trauma from motor vehicle accident, including traumatic brain injury, massive internal bleeding, and cardiovascular collapse. As the attending physician, I was responsible for confirming Isabella's death, according to established medical and legal protocols. I personally verified the absence of heart rhythm on our cardiac monitors, confirmed that she had no spontaneous breathing, and checked for the absence of pupillary response to light, eye standard tests that confirm brain death. Dr. Thompson and Dr. Kim witnessed my examination and concurred with the pronouncement of death. Our nurses documented the time, circumstances, and medical team members present at the time of death. These procedures are routine but critical because they create the legal record that establishes when and how a patient died. Isabella's body remained in our operating room for approximately 30 minutes while we completed post-mortem procedures and prepared her for transfer to the hospital morgue. During this time, she was disconnected from all monitoring equipment, and her body showed the unmistakable signs of death: fixed and dilated pupils, absence of pulse or breathing, and the beginning of algal mortis, the gradual cooling that occurs after circulation stops. The most difficult part of my responsibilities that morning was informing Isabella's family of her death. Sophie had been waiting in our family consultation room since shortly after Isabella's helicopter arrival, along with Isabella's parents, David and Marie Hartwell, who had driven up from Massachusetts during the night. I entered the consultation room at 3:47 a.m. to deliver news that no physician ever wants to give and no family ever wants to receive. I explained that despite our team's best efforts over 6 hours of surgery, Isabella's injuries had been too severe to survive. I described the extent of her trauma, the procedures we had performed, and assured the family that everything possible had been done to save her life. The family's grief was profound and heartbreaking. Sophie collapsed in tears, repeatedly asking if there wasn't something more we could try. Isabella's parents sat in stunned silence, struggling to process that their healthy, vibrant daughter was gone. I spent nearly an hour with the family, answering their questions, explaining the medical circumstances of Isabella's death, and connecting them with our chaplain and social services coordinator for ongoing support. Following my conversation with Isabella's family, her body was transferred to our hospital morgue, where it would remain until arrangements could be made for funeral services. The hospital's pathologist, Dr. Richard Chen, completed the required documentation for the death certificate, noting the cause and manner of death based on our surgical findings and the circumstances of her accident. Because Isabella's death resulted from a motor vehicle accident, Vermont state law required notification of the medical examiner's office. However, given the clear circumstances of her injuries and the extensive documentation from our surgical team, no autopsy was deemed necessary. The medical examiner concurred with our determination that Isabella had died from multiple trauma sustained in her rollover crash. Over the following days, Isabella's case was reviewed as part of our hospital's standard quality assurance process. This review, conducted by physicians who had not been involved in her care, examined our treatment decisions, surgical procedures, and protocols to ensure that appropriate medical standards had been followed. The review concluded that our trauma team had provided excellent care under extremely challenging circumstances, and that Isabella's injuries had been non-survivable regardless of the medical intervention provided. This quality assurance review was important both for maintaining hospital standards and for providing closure to our medical team. Emergency medicine involves regular exposure to tragic cases where patients cannot be saved despite optimal care. The formal review process helps ensure that we learn from each case while also confirming that medical teams should not carry guilt or self-doubt when dealing with injuries that exceed the current capabilities of medical science. Isabella's funeral service was held on November 14th, 2020, at the Unitarian Universalist Church in Burlington. Several members of our trauma team attended, as is common when we have developed a connection with a patient's family during treatment. The service was a celebration of Isabella's life, focusing on her environmental work, her love of Vermont's outdoors, and the impact she had made on her community during her 28 years. Sophie spoke at the service about Isabella's passion for renewable energy and her belief that individual actions could help protect the environment for future generations. Isabella's colleagues from Green Mountain Solutions established a scholarship fund in her name for students pursuing environmental engineering degrees. The local climbing community organized cleanup efforts at several popular climbing areas that Isabella had frequented. For our medical team, Isabella's death represented a tragic but unfortunately routine outcome in emergency medicine. Her case was discussed during our monthly mortality and morbidity conference, where we review challenging cases to identify any potential improvements in our protocols or procedures. However, the consensus was that Isabella's injuries had been beyond the scope of current medical intervention, and our team had performed appropriately under the circumstances. I personally struggled more than usual with Isabella's death, perhaps because she was close to my own age, and reminded me of several friends who shared her environmental interests and active lifestyle. However, I was able to process these feelings through our hospital's employee assistance program and by discussing the case with colleagues who had experienced similar losses during their careers. And emergency medicine requires developing psychological resilience and the ability to compartmentalize tragic outcomes. While we never become completely immune to the emotional impact of losing patients, we learn to focus on the cases where our intervention does make a difference, and to accept that some injuries simply cannot be survived regardless of the quality of medical care provided. In the weeks and months following Isabella's death, her case gradually became simply one entry in my mental catalog of complex trauma cases. I continued working at Riverside General, handling hundreds of additional emergency surgeries, consulting on numerous trauma cases, and maintaining my role as head of emergency surgery. During 2021 and 2022, I performed some of the most challenging and successful surgeries of my career. I saved patients with injuries similar to Isabella's, successfully managed complex multi-trauma cases, and helped train a new generation of emergency physicians and trauma surgeons. Isabella's case had been tragic, but it represented the reality of emergency medicines. Despite our best efforts and most advanced techniques, we cannot save everyone. I had no reason to think about Isabella Hartwell again, beyond the occasional reference to her case during teaching sessions or quality improvement discussions. Her death had been thoroughly documented, properly reported, and appropriately reviewed. She had been buried, mourned, and memorialized by her family and community. In the medical records of Riverside General Hospital, Isabella Hartwell's file was marked as deceased with a death date of November 9, 2020. Her case was closed, and I had moved on to the thousands of other patients who would require my attention over the following years. That all changed on March 15, 2024, during what started as a routine Friday evening shift at Riverside General. I had been at the hospital for about 6 hours, handling a typical mix of emergency cases, a heart attack, several accident-related injuries from the spring skiing conditions, and a complicated appendectomy that had required more time than expected. At approximately 9:23 p.m., our emergency department received a walk-in patient who reported a minor ankle injury sustained while hiking near Mount Mansfield. The initial triage nurse, Janet Stevens, documented the case as a routine orthopedic evaluation, a 31-year-old female with suspected ankle sprain, no apparent complications, low priority for emergency intervention. I was completing notes on a previous case when Janet approached me with a somewhat puzzled expression. "Dr. Vasquez," she said, "I have a patient in bed 7 with an ankle injury, but there's something odd about her registration information. The computer system is showing conflicting records, and I can't get her insurance information to process properly." Computer glitches were not uncommon in our electronic medical records system, particularly with patients who had been seen previously at our hospital. Sometimes the system would create duplicate records or fail to properly link previous visits with current registrations. I assumed this was a routine technical issue that could be resolved with a quick review of the patient's identification and previous medical history. "What's the patient's name?" I asked while finishing my notes on the previous case. "Isabella Hartwell," Janet replied. "She says she's been a patient here before, but the system is showing some kind of error message when I try to access her previous records." I looked up from my computer screen, certain that I had misheard the name. Isabella Hartwell was a name I would never forget. The young environmental engineer who had died on my operating table 3.5 years earlier, but that was impossible. Isabella Hartwell was dead. I had pronounced her death myself. "Did you say Isabella Hartwell?" I asked, trying to keep my voice steady. "Yes, that's right. Room 7, ankle injury. Should I have someone from IT look at the computer issue?" I stared at Janet for several seconds, my mind racing through the possibilities. Obviously, this had to be a different Isabella Hartwell while not a common name. It wasn't impossible that 2 people with the same name might be patients at our hospital, or perhaps there was some error in the medical records system that was creating confusion with the deceased patient's file. "I'll take a look at her myself," I told Janet, standing up from my workstation. Sometimes it helps to have the attending physician review these registration issues directly. As I walked toward examination room 7, I tried to rationalize what I was about to encounter. This would be a different person who happened to share a name with a deceased patient, or perhaps someone using a false identity for insurance reasons, or maybe a family member of the deceased Isabella who was using her name and information for some reason. But when I pulled back the curtain and looked at the patient sitting on the examination table in room 7, every rational explanation evaporated. I was looking at Isabella Hartwell, not someone who resembled her, not a family member with similar features, but the exact same woman who had died on my operating table on November 9th, 2020. The same face, the same build, the same distinctive scar on her left hand from a childhood accident that I remembered from her previous medical records. Isabella looked up at me with a friendly smile and said, "Hi doctor, I'm sorry to bother you with something so minor, but I think I may have sprained my ankle pretty badly during a hike today. It's been bothering me for several hours, and my partner thought I should have it checked out." I stood frozen in the doorway, staring at a woman who should not exist, who was speaking to me as casually as any other emergency department patient who was asking for help with an ankle injury as if she had not been dead for over 3 years. Standing in that examination room, face to face with a patient whose death I had pronounced, whose body I had seen transferred to the morgue, whose funeral I had attended, I felt the foundation of everything I believed about medicine, death, and the nature of reality begin to collapse around me. Isabella Hartwell was sitting in front of me, alive, breathing, and completely unaware that she was supposed to be dead. She showed no signs of recognition that we had met before, no memory of her fatal accident, and no awareness that her very existence was medically impossible. What happened next would challenge every principle of medical science I had learned during my career. force me to question my own sanity, and ultimately lead me to abandon the profession I had dedicated my life to pursuing. But that encounter, and the investigation that followed, is a story that still haunts my dreams, and one that I'll share with you in the next part of this impossible case. Because what I discovered about Isabella Hartwell would prove that everything I thought I knew about life and death was wrong. Standing in examination room 7, I forced myself to examine Isabella's ankle with trembling hands. She was real warm skin, strong pulse, completely alive. I ran every test possible, blood work, Connecticut scans, x-rays, all came back normal, showing no evidence of the catastrophic injuries that had killed her. Isabella, I said carefully, what's the last thing you remember clearly? She looked puzzled. I remember starting my hike this morning. But honestly, doctor, I've been having memory gaps lately. Sophie says I've been confused about dates. I can't remember much from the past few years. I checked our hospital database. Isabella's death certificate was still there, dated November 9th, 2020. Surgical notes, morgue records, autopsy reports. I've everything confirmed she had died on my operating table. Yet here she sat, asking about her sprained ankle. When Isabella returned 2 weeks later with Sophie, everything unraveled. Sophie recognized me immediately as the surgeon who had pronounced Isabella dead. Dr. Vasquez, you told me Isabella was dead. I buried her. I grieved for 3 years. How is she here? Isabella looked confused. Sophie, what are you talking about? That confrontation shattered my denial. I reported the case to hospital administration, knowing it would end my career. Within 48 hours, they classified it as a clerical error and sealed all records. I was placed on administrative leave. 8 months ago, I resigned. I moved to New Hampshire and opened a small practice, avoiding trauma cases entirely. Isabella continues living in Burlington, healthy and happy with Sophie. She has no memory of death, no awareness of her impossible return. To everyone except Sophie and myself, she's simply a young woman who was always alive. But I know the truth. I pronounced Isabella Hartwell dead on November 9th, 2020. On March 15th, 2024, she walked into my emergency department, asking for help. Medicine teaches us death is final. Isabella's case proves everything we believe might be wrong. That realization ended my career and changed everything I thought I knew about life, death, and the impossible.